Welcome everyone. In today's video, we are going to talk about the posterior Moore approach to the hip joint. This is also known as the Southern approach. Now, this is a relatively safe and easy approach to the hip joint. However, it is only used in procedures where the femoral head viability is not necessary, because in this approach we cut the short external rotators, which lead to injury to the deep branch of medial circumflex femoral artery, which lies in close relationship to these rotators. So the indications for this approach are total hip arthroplasty, hemiarthroplasty, and resection arthroplasty like girdlestone arthroplasty. The main advantages are that the abductors are not cut, so it avoids loss of abductor power compared to the lateral approach. And this is a very extensile approach with excellent exposure of the acetabulum and the femoral shaft. So this is very suitable for revision surgeries. The main disadvantage is there are higher dislocation rates reported with this approach, and the dislocation in this approach occurs posteriorly on flexion and adduction of the limb. Now, let us look at the technique of this approach. The position is lateral decubitus position with the affected side up, and a 10 to 15 centimeter long incision is used, which is curved posteriorly and is centered over the posterior aspect of greater trochanter. Now, the practical way to take this incision is to flex the hip to 90° and take a straight incision centered over the posterior aspect of greater trochanter. When you bring the limb back to normal position, we get this smooth posteriorly curved incision. Following this, the fascia lata is cut in line with the incision and gluteus maximus is split along the line of its fibers. Now, following this, the short external rotators come into view, and over them we have this layer of fat. Now we have to remember the sciatic nerve runs in the back of the thigh over the short external rotators encased in this fatty tissue. Now if we try to dissect this sciatic nerve, we will encounter a lot of bleeding. So what we do is we internally rotate the hip to bring the insertion of these rotators into view, and we push the fat posteriorly. So pushing the fat posteriorly and rotating the hip internally puts the sciatic nerve away from the field, and now we can see the insertion of these rotators and we can cut them. Before cutting, we put stay sutures in the external rotators, especially the piriformis and the obturator tendon. And then we detach these external rotators 1 centimeter from the insertion into the posterior aspect of the greater trochanter. Following this, the external rotators are laid back over the sciatic nerve, which further protects the sciatic nerve during the procedure. Now when the external rotators are cut, the capsule comes into view. The capsulotomy is performed either through a straight incision or a T-shaped incision. When the capsulotomy is performed, the femoral neck and head comes into view, which can be dislocated by internal rotation of the hip. Now once the hip is dislocated, we can do the desired procedure and repair the capsule following the procedure and reattach the short external rotators. In a total hip arthroplasty or a bipolar hemiarthroplasty done through this approach, the repair of the capsule and reattachment of the short external rotators is extremely important to prevent posterior dislocation of the hip joint. Now let us have a look at the dangers in this approach. The first structure at risk is the sciatic nerve, which lies over the external rotator encased in the fatty tissue. So the first maneuver is to push the fatty tissue posteriorly and internally rotate the hip, which takes the sciatic nerve away from the field. The next risk is the sciatic nerve being crushed by the retractors. So for this, we have to ensure the retractors are placed over the cut surface of the rotators and there is no direct contact between the retractor and the sciatic nerve. The second structure is the inferior gluteal artery. The branches of this artery may be injured when the gluteus maximus is split. And if the bleeding is troublesome, we have to identify and coagulate these branches. Now the main trunk of this artery emerges beneath the lower border of the piriformis from the greater sciatic notch. Now, if a pelvic fracture involves the greater sciatic notch and it is approached through the posterior approach, this main trunk may be at risk, and after injury, this artery may retract into the pelvis. In this case, we require a laparotomy and occasional ligation of the internal iliac artery, which is the feeding vessel to this inferior gluteal artery. So friends, in this video, we discussed the posterior Moore approach to the hip joint, which is an extremely commonly used approach for total hip arthroplasty. If you like these videos, please hit the like button and subscribe to the channel for further videos. Also comment in the comment section regarding the topics you will like to be covered in the future videos. Thank you.